So a second degree type 2 or second degree Movitz type 2. It is similar to a type 1, but is missing one key feature. The PR interval on a type 2 stays consistent. There's no prolongation of that PR interval. You know what? Let's draw that a little more normal looking. So PR interval stays the same until eventually I have a P wave, but I have no QRS complex. So there's my PR, PR. We're going to pretend like those are the same. And then I have a P, but I have no complex. Now this could follow a rhythm. It could be every third beat, every fourth beat, every 10th beat, every whatever, but it does not have to follow a rhythm. It can just be really chaotic and all over the place. Oftentimes it does follow a normal pattern, but it does not have to. Again, the problem occurs when I'm missing ventricular complexes, so my heart is literally skipping beats. So the patient's heart rate gets bradycardia. They become symptomatic. That is the second degree Movitz type 2. We'll go ahead with a third degree on this video. I think I'm going to have enough time. So a third degree AV block is when it really starts to get dicey. Because in a third degree AV block, there is complete interruption of impulses through the AV node. So the SA node is still firing, but when the energy gets down to the AV node, it never makes it through. So the AV node just kind of holds the energy and it never lets it get into the ventricles. So because of that, the ventricles take over as their own pacemaker. That's where this comes into play. So we have two independent rates. We have an atrial rate and we have a ventricular rate. Let's start with the atrial. Since we have depolarization of the SA node, we're going to have upright P waves. And since there's not an SA node problem, those P waves should be fairly equally spaced. And the rate should be somewhere between 60 and 100. Of course, it can be a little slower or a little faster. The P waves will march out with each other because, again, there's not a atrial problem. That P to P interval should stay constant. But because no energy is making its way into the ventricles take over as their own pacemaker. So, when we have a ventricular complex, a complex which originates in the ventricle, similar to that of a PVC or a VTAC that we learned a couple of weeks ago, then we learned that the complex normally is wide. It's normally greater than 0.12 seconds or 120 milliseconds. And that is true most of the time with a third degree AV block, but it doesn't have to be, because it depends on where in the ventricles this pacemaker site originates. So if it's way up high, if that's where the impulse from the ventricles is coming from, then we're going to have a fairly normal route of ventricular depolarization. So you're not going to have this big, wide, huge, bizarre complex. But if the pacemaker site was somewhere way down here, then you're going to have a really weird looking complex, and it's going to be wide, and it's probably going to be upside down if we're looking in lead 2. We'll have an inverted complex because we're moving primarily away from that positive electrode that's on the left leg in lead 2. But it is subjective, so you don't have to have big wide complex. It doesn't have to be an inverted complex. What you will find, though, is that these complexes should march out with each other. We'll just draw this one big and wide. They should march out with each other, but they're going to be slow. So, QRS, QRS, QRS. The QRSs march out with each other. Now look at this PR interval. Oh wait, there's not a PR interval in a third degree AV block, and that's because there is no correlation between the P wave and the complex. The P waves march out with each other. The complexes march out with each other. The P waves and complexes are not correlated in any way, shape, or form. So I have two independent rates. Excuse me. It is certainly possible, and this one kind of does it here on the end, for you not to see a P wave. The P wave could be completely hidden within the complex. And the reason for that is if you have atrial depolarization and ventricular depolarization occurring at the same time, which are you going to see? You're going to see ventricular depolarization, hence why you don't see a P wave with a junctional rhythm from time to time. So again, the problem with a third-degree AV block is not necessarily that it is a block, it's that the rate gets really slow because ventricular depolarization comes from the ventricles versus following the normal route of depolarization. Additionally, you lose the atrial kick, which is the blood the atria pumps into the ventricles, so your preload is reduced, which oftentimes makes the patient's blood pressure even lower.